Hello and welcome to ECMO 1. This intended audience is for those in general pediatric surgery, although of course you're welcome to watch it if you're not in that audience. We'll be talking about who to put on and how to do it. There's an appropriate quote from Galen, who was describing ECMO 200 years CE. All those who drink of this remedy recover in a short time, except those in whom it does not help, who all die. Therefore, it is obvious that it only fails in incurable cases. The usual disclaimer here, no conflicts of interest, but this was all collected by one person, and there may be other correct ways of doing similar things. Checklist for if you're in pediatric surgery and critical care fellowship of things to do. First, we'll be talking about ECMO, the team, the equipment, and then we'll be talking about who to put on, how to evaluate them, and the techniques for cannulation. Without further ado, the ECMO team. A little bit of a subtle difference here. A perfusionist can do both ECMO and cardiac bypass. An ECMO specialist is either an RN or RT with special ECMO training who does ECMO in the ICU but does not operate cardiac bypass machines elsewhere, for example, in the operating room. Numerous other components to the team, the intensivist team, of course, nurses, surgical team, respiratory therapists, PT, OT, many more, dietitians, of course. Let's review the ECMO equipment. We'll talk about the machine and its components, as well as the cannulas. This is a little circuit diagram I made with the venous reservoir, a hemofilter, the pump, membrane lung, aka the oxygenator, heat exchanger, and a bridge. The venous reservoir, or bladder, is not always a component of modern ECMO circuits, more often for cardiopulmonary bypass procedures. It is used to add compliance and to prevent excess negative drainage pressures, as well as have a place to return blood to during an operation, you can see also the hemofilter going into there as well. The hemofilter is not always present, similar to the reservoir. It is used to provide renal replacement therapy through an ECMO circuit. It's one of three ways to do that. The other two are using an integrated system or using a renal replacement device in a parallel system using an access point. Pumps, the things that make the blood go forward. Two main types of roller pump, which is a fixed output. As the pump rolls along the tubing, there's a peristaltic compression. Generates more negative pressures on the drainage side than the centrifugal pumps and can cause some cavitation. Some studies show lower rates of mechanical cardiac complications, lower mortality in children with roller pumps. However, those differences are probably less valid in with modern centrifugal pumps, which may have originally had more hemolysis, but more modern designs and limiting higher RPMs has limited that. The membrane lung, aka the oxygenator, an array of synthetic tubes made of some polymers, which provide an interface for gas exchange similar to the alveoli. Adds oxygen to the blood, removes CO2, can have an integrated heat exchanger. This is sometimes where you'll see clots form. This is also where you can see things like condensation develop when we talk about the troubleshooting steps in the next ECMO chapter, which is fixed by increasing the sweep gas briefly, so-called sighing the oxygenator. This is the heat exchanger. It maintains blood and therefore patient temperature. It can sometimes be integrated into the membrane lung. Otherwise, the circuit going through the room temperature air would lose a lot of its heat. It can also mask fevers, and so institutions have different protocols for monitoring for infection in patients on ECMO. Another optional component, the bridge, is a shunt from the infusion to the drainage side of the ECMO circuit, usually close to the patient. It can be used to recirculate blood through the circuit without pausing flow, which prevents circuit clotting. This is used when the patient is either being weaned from ECMO support or when a component needs exchanged or clots removed. And this is the entire circuit altogether. In this case, it's a VA model. You can see blood is being taken from the venous cannula to the reservoir through the pump. Some of that pumped blood goes back through the hemofilter. The rest of it goes to the membrane lung oxygenator, through the heat exchanger, and back to the patient. And this color differentiation is something that you want to look out for as well to make sure that your blood is being properly oxygenated. All right, let's talk about some cannulas, different sizes and what that means for flow. We'll talk about single site and two site VV access there, as well as VA cannulas. There are other options which we'll not talk about in this presentation, VVA ECMO, VAA ECMO, where you have more than one venous or arterial cannula, as well as ECCC O2R, which is a special type of ECMO specialized for just CO2 clearance. All right, let's talk about cannulas. You can see that there's a nonlinear relationship between the pressure drop and flow across a cannula, and that shape of that curve is different and more steep for the smaller cannulas. For example, for a 13 French cannula to go from a flow rate of a ½ liter per minute to 1 liter per minute would take the pressure drop from 100 to almost 300, whereas for the larger cannula to go a similar rate from 0.5 to 1, you see almost negligible pressure changes. And this can have a great effect. Almost always want to have the biggest cannula size that the vessels will tolerate. Sometimes in shock, those vessels can appear smaller, but they will be able to accommodate a larger cannula. And so it's a good idea before cannulating to talk to your ECMO specialist or perfusionist and see what kind of flows you're going to be needed for the condition that you're trying to treat, and what size cannula you should try to target to meet those demands. Those folks will have a card that looks something like this based on the cannulas that they have in stock at your facility, and it'll tell roughly based on weight what size cannula is appropriate. Keeping in mind that some conditions, for example, certain cases of septic shock may want higher flow and may need larger cannulas. All right, VV can be done through two sites. In this case, on the X-ray here, you can see it in the internal jugular vein on the right side, as well as going up one of the femoral veins and draining from the junction of the hepatic veins with the IVC, and then being reinfused closer to the heart. More commonly nowadays, you'll see single site access for VV ECMO, either through Avalon Elite, which is a bicaval cannula. The Origin has been pulled from the market, but the other competitor is the Crescent from Medtronic, which has both bicaval and right atrial options. Over here on the screen right, you'll see a bicaval. You'll notice that the reinfusion line is pointing anterior, which puts the reinfusion port in the correct configuration to redirect that jet towards the right atrium and tricuspid valve. The distal tip ends at that junction where the hepatic veins meet the IVC. How to select between bicaval and right atrial catheters. They both go down to a smaller size, 13 French, although the distance between the distal infusion port, the distal drainage port, and the reinfusion port is much shorter in a neonate, and that makes the bicaval option more challenging. The bicaval ones are generally placed with fluoro guidance to make sure that the wire and thus the cannula go into the IVC and not into the right atrium and ventricle. Additionally, in neonates, there's a relatively low contribution of blood return from below the diaphragm, especially if those patients are NPO and non-ambulatory. And so there's not much advantage to having the main drainage cannula be at that site in the smaller patient, and especially the neonate. Be aware of what cannulas you're carrying and what they look like on X-ray. As you can see from these photos, there was some older cannulas where it looks like the cannula ends here on X-ray, but there's actually a small dot that you'll see here. and the cannula actually goes all the way down there. They've since reinforced it all the way to the tip so that the cannula looks like this. But just keep in mind what your cannulas look like under X-ray, so that you know exactly where the tips are. Indications for which ECMO has shown clear benefit. There are a bunch of these. For VA ECMO, some congenital cardiac disease, as well as cardiomyopathies or dysrhythmias with treatable and transplantable options, keeping in mind that ECMO is typically a bridge to therapy or to recovery, rather than to replace or cure any condition. Excellent outcomes in persistent pulmonary hypertension of the newborn, as well as meconium aspiration with survival rates exceeding 90%. Some CDH is failing conventional therapy, some hypothermic arrest, and then for VV, obviously the big one is acute respiratory failures, such as pneumonias and other infectious causes, persistent air leaks, either from infection or trauma, inhalational injuries, ARDS, failing conventional therapies. Also post-traumatic pneumonectomy, which we'll talk about during a little trauma slide later on. And then meconium aspiration and CDH can also be VV or VA, depending on the size of the infant and surgeon preference, institutional preference, as well as how sick the infant is and whether or not they're requiring vasoactive support or inotropic support. That's consensus for pulmonary embolism, with some studies in adults showing no survival benefit in that circumstance. Septic shock, as well, controversial in pediatrics. ECMO does a decent job at replacing gas exchange function of the lung as well as the cardiac function of the heart, but it is not as good at compensating for low systemic vascular resistance, and the use in sepsis sometimes requires high flow, and the outcomes for those patients have not been as good. And then ECPR, which is extracorporeal cardiopulmonary resuscitation, still trying to figure out exactly what population benefits most from that intervention. Let's talk about septic shock for a minute. So the use of ECMO for refractory septic shock in pediatrics remains somewhat controversial. There seems to be at least 3 different subtypes that are broken down in the literature. The first is primarily right heart failure, respiratory failure. And this one can be supported with VV ECMO with lung rest, and the reduced intrathoracic pressure and optimization of oxygenation will improve myocardial performance, peripheral circulation, and they'll often be able to wean from their vasoactive or inotropic support. And these folks generally have good outcomes on ECMO. The second subtype is septic cardiomyopathy or hypodynamic shock with severe, although temporary, LV dysfunction, low cardiac output, and VA ECMO can be used as a bridge to recovery, which usually happens within days. Specifically for this subtype, look out for left atrial distension while on ECMO, which we'll talk about more in the second ECMO lecture. Left atrial distension while on ECMO caused by poor LV function can lead to pulmonary edema, hemorrhage, and mainly atrial decompression, and we'll talk about the different ways to do that. And the lab subtype is distributive or hyperdynamic shock with high cardiac output and low systemic vascular resistance. ECMO does a poor job at compensating for that. In this subtype, it seems like higher flows are better, often in the 150 to 200 cc's per kilogram per minute. And historically, central cannulation is thought to be needed for that, although that is still somewhat controversial, and there are some centers doing peripheral ECMO, which we'll talk about. So this is one study looking at close to 2,500 children with sepsis, of whom 164 had septic shock. And they did not show a survival benefit to ECMO in those patients with severe septic shock, with survival to discharge 40% with conventional therapy versus 50% for ECMO. When they broke it down a little bit more, they found that the most benefit to ECMO was in those children who had suffered an in-hospital cardiac arrest, where survival to hospital discharge was 18% with conventional therapy versus 42% with VA ECMO. And about 2/3 of those ECMO cannulations were during ECPR conditions. They did find that survival was significantly higher in patients who received flows greater than 150 cc's per kilogram per minute, and survival in that group was 82%, compared with children who received standard flows, where survival was 43%, or conventional therapy with survival of 48%. So overall, this suggests an agreement with prior literature saying that higher flows seem to do better. And interestingly, that the most benefit may be seen in those patients who are the sickest, those who have undergone a cardiac arrest. Talking specifically about peripheral versus central cannulation, historically, central cannulation for septic shock was thought to be superior due to the ability to achieve higher flows, but up to 200 milliliters per kilogram per minute. And this data from two studies from McLaren et al. Really drove kind of decades of thinking along this topic, but peripheral via ECMO is now used successfully in many centers for pediatric patients in septic shock, including Kansas City, where I trained. And this is one study from two hospitals in Indiana and UT Southwestern, peripheral venous arterial ECMO for refractory septic shock in children, which was published earlier this year. And it was a group of 40 patients over 14 years who were peripherally cannulated, with overall survival comparable to those centrally cannulated. They found on their analysis that achieving higher initial flows within 2 hours of cannulation was associated with improved survival. But rather than it being 150 to 200, they showed their difference between 100 and 76 or so. Higher flows may be harder to achieve in smaller children due to that nonlinear relationship we were talking about between flow and cannula size. One thing to think about when trying to decide between central and peripheral cannulation, in addition to surgeon and institutional experience. The successful experience in Stockholm, Sweden, and other places, including, as I said, in Kansas City, where I trained with exclusive peripheral cannulation for sepsis, argues that the initial flow may not be important as historically thought, and peripheral cannulation can be a viable strategy for these patients. ECPR, another area of controversy, seems to have better outcomes in children with congenital cardiac disease or primary cardiac etiology for their CPR, and at most places is currently only being offered for in-hospital arrests due to poor outcomes with out-of-hospital cardiac arrest. And this is a recent publication from April of this year looking at outcomes of extracorporeal cardiopulmonary resuscitation for in-hospital cardiac arrest among children with non-cardiac illness. And they limited, interestingly, their study to children who were cannulated more than 30 minutes from the initiation of compressions. And they concluded that there was not a statistically significant survival benefit with the usage of ECPR using frequentist statistics. However, when they looked at it with the Bayesian model, they thought that there was a probability of treatment benefit. So their conclusion here at the bottom, no clear survival advantage to ECPR, but the possibility of benefit support the ongoing development of ECPR systems and further study. So still not exactly clear which population to offer this to for maximum benefit. Contraindications, there used to be a lot of these, and even a lot of the absolute ones have become relative or even non-indications. Formerly, oncologic processes were thought to be a contraindication, but now there's a discussion regarding prognosis, and in patients with good prognosis, they are offered ECMO. Irrecoverable underlying conditions, terminal genetic diseases, or devastating neurological injuries, certainly more towards the absolute, as well as contraindication to anticoagulation, although ECMO can be run at least for short times without anticoagulation, so not necessarily a complete absolute contraindication. Formerly, 1 to 2 weeks on a ventilator or extremes of prematurity people are going lower with both the degree of prematurity and the weight of the child. And then fungal pneumonias, severe immunodeficiencies, long duration hypoxic cardiac arrest without adequate CPR, although how long exactly is that? It seems like after 30 minutes there are poor outcomes, but no one knows exactly what time is too much. The only absolute contraindication is if there's nothing cannulatable. The use of ECMO in trauma, once thought to be a contraindication and historically discouraged, is now being used with pretty good outcomes in adults and children, sometimes in cases with no systemic anticoagulation, if they have, for example, traumatic brain injury, which is not an absolute contraindication. And pretty good survival rates, 74% survival in 85 children, published by Jacobs in Journal of Trauma and Acute Care Surgery in 2015. And then the largest, looking at 573 patients, had a 55% survival. That included both VA and VV ECMO with a roughly 50-50 split. They did have a significant proportion of drowning patients, including in that study, but there were also burns, thoracic trauma as the next two biggest populations. Survival outcomes were overall better for VV ECMO at 74%, although 41% also not bad for VA ECMO. And interestingly, there were not increased rates of hemorrhagic complications. They're similar to ELSO historic rates, as were overall complications. So trauma should not be an absolute contraindication to ECMO. What are the indications in trauma? Severe thoracic trauma with ARDS or severe air leak, trauma pneumonectomy, a rare procedure, but the instant pulmonary hypertension can strain the right ventricle, leading to dysrhythmias and death. Neither trauma nor head injuries are absolute contraindications. And as we discussed earlier, similar rates of hemorrhage. And if there is concern for hemorrhage, there are multiple different ways to reduce the anticoagulation strategies on ECMO, including going anticoagulation free for a short time. And this was a study from 2023 with 35 patients between 3 months and 91 months of age, most of whom were on VA ECMO. And most of these patients had no heparin load at the time of ECMO initiation and underwent anticoagulation periods for between 13 and 26 hours, with ECMO durations between 64 and 217 hours. Low rates of bleeding, low rates of clotting, 77% survival to decannulation with a 50% survival to hospital discharge. And this is largely possible because of newer heparin-bonded circuits, which enable the possibility to do anticoagulation-free ECMO for some period of time. So, when to consider ECMO and how to decide between VA and VV ECMO. So, the oxygenation index is one criteria that's perhaps most widely studied. It's calculated by the mean arterial pressure divided by the PF ratio. And when it approaches 30 or even above 30, ECMO begins to have a survival advantage over conventional therapies. Ventilation index, less often used, uses CO2 instead of O2. And then deciding between VV and VA ECMO, the vasoactive infusion score can be helpful, knowing which drips are on and how many. Some surgeons or institutions will say that if the vasoactive infusion score is 20 or above, using that as a deciding factor to go more towards VA ECMO, although there's not an absolute number that's in any textbook. It'd be helpful to know recent echo, structural heart problems, and LV-RV function, knowing that RV function in particular can improve with VV ECMO. A recent X-ray, and then any contraindications, as well as current or formal central venous access. The advantages of VV ECMO is that you maintain the pulsatile blood flow, you avoid carotid ligation or potential injury. Although we'll talk about in the second ECMO lecture that there is not as much difference with neurological complications as you might think. The mixing of blood results in a lower peripheral O2 saturation than on the VA ECMO, and so V greater than 80% peripheral pulse ox acceptable on VV ECMO, especially initially. There is easier weaning because you can simply keep running the ECMO flow while turning off the oxygen and sweep gas, since you're not contributing really to cardiac output. The ECMO main advantage is it allows for cardiac support, myocardial arrest. Along with that, it can cause myocardial stunning and loss of pulsatility. But the biggest advantage is that it can support blood pressure, whereas VV ECMO largely cannot. All right, prepping for ECMO cannulation. This can sometimes be done, needs to be done fairly quickly, and so what should you do before the entire team gets there? First, decide OR versus bedside, which is dependent on patient stability, as well as the need for things like fluoro, which is better done in the operating room. And fluoro is largely preferred for the bicaval percutaneous VV ECMO strategy. It's helpful if there's not one present to get an arterial line, and then to move infusions away from the planned ECMO cannulation site if you're planning to go into the internal jugular, for example, and that's where a triple lumen with all of the patient's vasoactives are infusing, then that could be potentially problematic during the cannulation. If this is going to be an ECPR situation, make sure that there's enough headlights for the surgeon and assistant, or at least one of those. Get that patient over to the top right corner of the bed with the head tilted to the left and a shoulder roll in place. You're not going to be able to reach the neck or get access to the vessels if they're in the middle center of the bed. And then select the cannulas and prime the circuit. Whether that's a blood or a clear albumin, prime will depend on the size of the patient and what you're doing. How to select cannulas? So this is going to be dependent on the patient weight and desired flow, and sometimes also their height. And if you're going on bicaval VV ECMO, try to pay attention and try to get a length from an X-ray of this F catheter. This is between the tip of the cannula and where that reinfusion port is, and try to see, in addition to overall catheter length and size, meaning width, French, see if you can get a sense on X-ray or CT, the distance between the right atrium and the hepatic veins, and try to find something that would be similar, so that you're not being constantly asked to either reposition where the infusion port is to direct it towards the right atrium, but then losing your drainage and getting higher pressures and chugging on the circuit because it's in an improper position. It's nice to have both of them obviously in the right position. Technique for going on VV ECMO, and this is mostly talking about single site access, which is the majority of the cases that we see nowadays. Typically prefer percutaneous IJ access with an ultrasound, especially in the larger patients. Without the cut down, that makes removal easier. You can simply pull the cannula and hold some pressure. So bicaval access requires real-time fluoro, although some people are using echo or X-ray if they do not have access to fluoro. But the important thing is to make sure that the first wire, usually a super stiff wire such as an Amplast or a Lunderquist, goes into the IVC and not into the right atrium, right ventricle. Once you have wire access, go ahead and heparinize the patient if you're going to do that, and then do serial dilations to get slightly above the cannula size. Making sure that while you're doing those dilation steps, some people do that under fluoro, but it's important to make sure that the wire freely moves back and forth and that if you're meeting in resistance, not to force your way through and cause a wire kicking in the subcutaneous tissue, because that can really make the cannulation difficult. Then place the catheter, go on pump, confirm its location with echo or x-ray, and secure it in at least 2 places, making sure that the orientation of the reinfusion cannula is pointed anteriorly. Major pitfall again is putting that wire into the right ventricle instead of into the IVC and risking perforating the heart with a dilator. And then secondly, kinking the wire and having to redo the stick-in wire. For the right atrial cannulas, 2 main options, maybe there's others too, but option 1 is to do a cut down, isolate the jugular vein similar to a cut down on the neck for VA ECMO, ligate proximally and then heparinize, or heparinize and then ligate, and then rather than to do a cylinder wire technique, to do a direct entry with the obturator into the vein and look at its location under real-time echocardiogram guidance, and then to go on pump and secure the cannula and close the skin. Option 2 is similar to the percutaneous method for the bicaval with wire access and dilations under Seldinger. There's also a hybrid approach where you can do a cut down and then make a stick slightly above that and watch the cannula go into the vein through your cut down, and that can let you do the same removal technique while having the advantages of ensuring that your catheter goes into the vein. The jugular in especially small children and infants is small and fragile, and it can be difficult to salvage the cannulation if a percutaneous method fails initially. And this is an echo of what a bicaval cannula placement might look like in an infant, and you can see the drainage port is in the right atrium, and then the reinfusion port higher up on the cannula with a jet heading towards the probe port towards the tricuspid valve. Going on peripheral VA ECMO, most commonly through a neck cut down with a transverse incision just above the clavicle, although some folks also use an incision anterior to the SCM like you did on your vascular surgery rotation for carotid endarterectomy. And then blunt dissection either anterior to the sternocleidomastoid muscle, which is my preference usually, although some folks also go either through or between the heads of the SCM or posterior to the SCM muscle. In either case, you're going to end up isolating the jugular vein and the common carotid artery, excluding the vagus from nerve injury, and then getting a good circumferential posterior dissection to make sure that when you put your ties, they're not stuck in the same spot. Going ahead and heparinizing, if that's indicated for your patient, and then ligating the vessel cephalad, performing a partial vessel transection, and cannulating going on pump. Some surgeons or centers do not ligate the vessels with the intention to perform later repair. The vessel can also be repaired after a ligation. There's currently insufficient data to favor either repair or non-repair. And some surgeons favor non-repair due to complications of carotid stenosis or clotting, which are not present with simple ligation. Percutaneous neck access or percutaneous femoral access or open femoral access are also options. Again, rare to do femoral arterial access in children due to limb complications. Options if you need to do that. You can either use a Gore-Tex chimney or a distal reperfusion catheter. There are many flavors to ECMO, but none are a cure for any condition. They're a bridge to either recovery or some other therapy. But please don't consider ECMO to be a last resort or a failure of your treatments. When you have that kind of mindset, it can result in additional physiologic or pulmonary injuries, or turn a situation which might have been an urgent ECMO into a ECPR with obviously poorer outcomes. Some recommended reading or watching in the case of YouTube. And some questions. The optimal location for a drainage port on a venous cannula is, that'll be over here. The liver hepatic veins entering the IVC kind of keeps the IVC open and prevents it from collapsing as the cannula is trying to pull in blood. An 8-year-old with pneumonia is in the PICU on fairly high ventilator support, hypoxic, with multiple pressors inotropics on board, with a structurally normal heart and a dilated right ventricle. The next appropriate step is to try an oscillator, INO, or cannulate for one of the types of ECMO. I personally would probably do this, knowing that after there's appropriate oxygenation and lung rest, you'll see that right heart function improve and likely see those pressors and inotropes able to come down. However, you would not be necessarily wrong, depending on certain additional details or surgeon preference, to say that one as well. And that's going to go ahead and conclude the first ECMO talk. I'll see you around.